Professor Qamar Abbas is the medical director and consultant in palliative care at St Clair Hospice in Essex, where he also resides. He's also a senior clinical tutor at the University of Cambridge. I was reading his bio and I thought, what am I doing with my life? He's also visiting professor in medicine with a portfolio in palliative medicine at Ibn Sina University in Pakistan. He's an associate lecturer at the Anglia Ruskin University, a lecturer for the postgraduate certificate in palliative medicine, and he also chairs a number of committees, the Race Equality Committee at the National Association for Palliative Medicine, sits on editorial boards, involved in writing and reviewing abstracts with 30 original review papers as well as book chapters, and is a regular speaker at national and international conferences on palliative care and medical ethics. Really, we're quite honoured to have him here, and has a number of postgraduate qualifications, which read a little bit like the alphabet I'm teaching my children. Additionally, he is an active speaker at Essex Jamaat programs, and also, quite incredibly, founded the Essex Jamaat Madrasa in 2008 and was the principal until 2018. So we really have someone quite special in our midst. During this talk, again, we had a few points for us to consider reflecting on. Some of them were, what do we assume about how we care for dying? I'm not sure how many of us have done palliative care, but if you've done it, as I have done it, it is an interesting specialty, and it certainly changes that. Do we recognize and name those transition points in our patients' cares? And as Muslim professionals, and I think as Dr. Munir mentioned earlier, the tension, how does that tension exist between, and how do we reconcile withdrawing active treatment with beliefs in perseverance, especially in light of the Islamic principle that Mawlana Saab has shown us of istishab. Please welcome him with a salawat ala Muhammad wa ala Muhammad.
Bismillahirrahmanirrahim. Esteemed scholars, Maulana Sayyid Muhammad Rizvi and my brothers and sisters, Assalamu alaikum. I mean, he was very right, because I thought I was just sending it for them to know me, and I said, please don't read it. One of the things which I wanted to read, which is important in today's discussion, very recently we had all the discussion about assisted dying in UK, and it has gone through the first reading and now being submitted for the second reading soon. And I had to represent Association for Palliative Medicine to APPG many times to put our points across. And the reason I said it, because that gave me a lot of time to research. Well, it didn't give me time, but I had to research a lot of perspectives. And the most important thing here is that when I was preparing for this discussion, and this is such a fantastic initiative by CoEJ to bring in end-of-life care discussion in our community, I struggled a lot, I will be honest. It was really hard to prepare slides or just think of the ideas, whatever I'm going to say. Because on one hand, we have got a strong faith, and some of our thoughts and values are positioned by our culture, our background, our upbringing. But on the other hand, we live and practice in the areas where there are regulatory restrictions, where there are legal points like assisted dying which are coming through. And then there is evidence-based practice, which we have to justify every single step. And as a human and as a doctor, I personally have come across a lot of tension inside me on those things. So first news for some of you, please don't shoot me for that. Even at the end of the day, we will leave a lot of questions than answers. Because I think it's important, when we are teaching at university, we are talking about end-of-life care. It is the very first discussion which I say to them, that you have to remember, even medicine, not just end-of-life care, is fluid. And the fluid is the treatment A which I give to one patient, I don't give it to patient B. Because we have to consider a lot of things. All the way from the biological makeup to that person's values, what he's allowing us to do and what he's not allowing us to do. Same way when I'm translating or transferring my knowledge from there to here, I have to remind, I have to look after those patients who will have very different values than I have. I will have to work with the teams which will have different regulatory instructions than I have. I have to work with those people where I have to reach a consensus which is acceptable. And hopefully, this is what we will try to do today, is actually navigate our way around. That with those restrictions, how do we get to the answer which is acceptable? Brothers and sisters, we have to remember, in United Kingdom, there are 365,000, and I apologize, I'm not talking about nurses and other professionals. As a doctor, I have got those stats for me. 365,000 registered doctors in United Kingdom by General Medical Council. 140,000 practicing doctors, face to face. Out of those, and I will just take a case study because I come from Pakistan, 21,000 plus doctors graduated in Pakistan, which will amount for something like about 14 to 15%. A lot of numbers. But you know what is most difficult for me to grasp? Before I said that, let me tell you another statistics. CQC, Care Quality Commission in UK, and General Medical Council, they look at the complaints and they look at what is happening. Last year, 54% of the complaints, when you put these together, were about end-of-life care. Just grasp that. Put all the obstetrics aside, labor deliveries, pediatrics, surgeries, 54% are end-of-life care and bereavement care. Go back to that 15% of Pakistani doctors. I do not know how many of these complaints were related to that. For 15% versus 31% of the complaints are against Pakistani graduate doctors. And now you can talk about racism and everything which goes on. But having sat on General Medical Council Complaints Committee many times, when I meet these people who are providing end-of-life care, it's quite often their ideas are modulated by their own thought processes where they graduated from. And that becomes hard for patients to grasp at times. So there's this tension as well, which we have to maneuver when we are doing all of it. And the last point I would like to make before I go to my slides, we are all, and I'm going to say something very controversial here, we all are made up of different makeups. Some of us have got very strong spiritual feelings and we will be modulated by that. But we are also living with those people who will have a different views than us within our community. But also, we will have got a generation which is now third or fourth generation, which has got different values than the first generations. I'm not talking about faith here. I'm talking about the culture and our reactions to the societal pressures. This all, we have to take that baggage and then transfer to end-of-life care. These are all restrictions which most doctors here and the clinicians here in the room will remember all of us had to face. Even if you talk about the British Native Society, when I'm looking after patients, their first generation will have different ideas of death and dying than the next one. Classic one, I looked after my dad at home, why can't my daughter look after me at home? The values have changed. And that has got impact on our own community. I have bored you enough to go back to my slide, but I'm trying to put a picture. This is what we are living in. And this is what we all have to accept. If I was doing a religious lecture at this time, I would say, Salawat ala Muhammad wa ala Muhammad. Now, as I said earlier, inshallah, I will try to finish in my time, whatever it is, but now I need your help. So, please, you are on different tables, please shout out. Am I allowed to take my mic and move around? This term, palliative care, you have heard many times. What does it mean? Can I ask this table? What does palliative care mean to you? Just give me some words, not the whole definition. End of life, thank you. That table, can't see the number. Eh, Table 2, please. End of life care is one idea. Anything else? What does palliative care do, for example? Relief to the suffering at the end of time in this world. Thank you. That's a very good one. Can I go to the sisters? And again, table 6. In the last days of life. Thank you very much. So it's a good snapshot of us saying that we are talking about end of life care, which is a very important aspect. Let's look at slide. It would have changed. This is a definition agreed back in 2002, and it still transpires in other definitions. First of all, I really want you to just ponder on this, because hopefully towards the end of the day, we will have an aim to go out with. This is what we want to do as community. So palliative care definition, first of all, okay, let me ask you the other question. Hospice, the world have about the hospice where we do palliative care. How long hospices have been around? Munir Bhai's table, whichever number it is, 4. 42 years. Well, that was very precise. Why did you say 42 years? You're just being Munir Bhai. Table 8, please. How long do you think the hospices have been around? 60 to 70 years. Table 9, please. 50 years. What do hospices do? Provide, I will come to the definition in a second, but general impression is end of life care, right? And care. So how long patients have been dying? 60 years? Since 42 years. But that's the point. Oh, okay. Do you know where is the oldest surviving hospice in the world today? Please. Kathmandu. Vishnava. Anybody on the table, whichever number it is? Okay, anybody? Where is the oldest surviving hospital in the world? No, Spain. Surviving we are talking about. There are evidence of hospitals in other places, but the surviving in a continuity. Iran, Egypt, Turkey. Okay, all of you can get in your cars, drive on the M25, M11 down there, St. Bartholomew. It's the oldest surviving hospital in the world, which was in 13th century. Why am I saying that? Because oldest surviving hospice in the world is the Hospice of Jerusalem, which predates Barts by more than 100 years. This is how old hospices are. Because people wanted to care. What does the word hospital mean? How was it born? Anybody? The word hospital. It comes from Latin. Hos and I will spell P-I-S, hospice. And Pitia, then T-I-A, added. It just simply means host and guest. This is how what the point is. This was the spirit of the hospice world and the palliative care. We wanted to care. So this is where I want to pull you back from that end of life care discussion. Firstly, palliative care is not a science. It's not a discipline. It's not a specialty. It's an approach, which all of us must have. This is how United Nations said, everybody in the world. In 2004, palliative care was recognized as a human right, that everybody should have access to it. So when we talk about end of life care, it's not just about end of life care. Because we are talking about quality of life for patients, but also importantly, families. And people who work in the clinical setups, we talk a lot about confidentiality and autonomy and individualization, but the definition recognizes patients die, families don't. And they live behind to tell a story of their own human suffering. And some of us who would have been through this situation will remember how hard it was when we tried to look after our parents, and even today we remember that. Another thing is, we don't talk about incurable diseases. Why? Any idea? It used to be incurable. They took incurable out, put life-threatening. Because if you take the whole ICD, International Classification of Diseases, give me a number. How many diseases are curable there? 14%. 86% we look after are not curable. Hypertension is not curable. Asthma is not curable. We control them. So that's why they took incurable out, put life-threatening in. So it could be now cancer, which historically it was always cancer only. But now it can be motor neuron disease. I mean, last week I had to go to European conference where my whole talk was about motor neuron disease and the palliative care needs and how they are met. And multiple sclerosis, heart failure, renal failure, kidney failure, that is. So that's what we have to remember. The community people we need to look after can have any of that. And how do we do that? Prevention and relief. So not just when they get it and we jump in to treat it. As society, we need to prevent their problems as well. And I will make a claim here, and I'm happy to be challenged on that. For definitely the clinicians, but by anybody. Please feel at liberty to make any comment. In my career, I have rarely seen bad death or suffering because of physical pain. It's almost all emotional and psychological and family suffering, which precipitates a bad death. And this is why I believe as a community we have a duty to get together and provide a setup for them so that they can be looked after. And we can all use skills. So if you look at the top skills, and this is agreed at international levels, these list of the skills. And this is not for specialist palliative care, it's for any community. So look at the top, that's obviously talking about the scientists or the doctors or the nurses, so ignore that. But if you come to number 3 onwards, we all need to have that in our lives if we want to look after that person. And may I dare say, it could be your own family member when we all get together to do that. And we need that listening. And somebody like me, my wife will tell you that I've got the least of it. So the point is, best communication skills is all hidden in our listening. Because sometimes we listen, and I always use this phrase, listen carefully what the other person is saying. And listen more carefully what they are not saying. But this is evident in their body language. Now, all of us, how many times have you said, I'm not angry? Listen carefully what I have just not said. And we need to empower ourselves, our community, our people who are ill. Empower to be honest with us. Now, look inside yourself. How many times you have said, I'm fine. I'm okay. I remember one of the junior doctors many years back, she was a GP trainee. And on the last CSR is the clinical supervisor report, which is done at the end of their training placement. So I asked her a question which is simply asked, what is one thing you learned from me, three things you learned from us so that we can write? And I wasn't expecting it, but I learned from her. She said to me, I learned from you, when you ask, how are you? You wait for the answer. Because how many of us have tendency to just, how are you? And then, yeah, get on with it. And so you don't have a choice other than saying, I'm fine. When you translate that to the patients like this and your family person, I would say in normal lives as well, we need to empower them to be honest with us. But all of that needs a lot of courage. And we need to know ourselves. We need to have, how do we deal with that? Looking after death and dying, whether it's in the community, as a professional. Now, anybody who has looked after these patients will remember it's really hard. Sometimes you walk in the patient's room and you think they look like your mom and your father. And at my age, they look like me as well. But important thing is, it hurts more when you're not expecting it. When you meet somebody and they want to share something, it really, really is difficult. So we need to know how will we cope with it. What is and there our teams become important, talking to each other within our community, within our surgeries, within our professional workplaces. And we need to reflect. What did we get right? Or what did we get wrong? What can we do again? What can we do differently as community to look after these people? And personally, we need to have that empathy, that patience. We walk at the patient's pace rather than our pace. Now, I know time is short for every single clinician in the world, but let me tell you another story. Back in, again telling my age, 1993 I graduated. Well, my batch 92, 93, because December exam finished, January I got the result. I got my first salary as the junior doctor. And as the tradition tells us, I took my salary to my father at that time, who was a doctor. And I said, this is my first salary. And he said to me, oh, now you are ready to listen to some advice. He gave me a lot of them. But this one I want to share. He said, student life was brilliant. You had a lot of fun. Now the real test starts. You will never go home on time, first message to you. You'll always be staying behind. As a doctor, you have to accept that. When we talk about protected timings, where are they? Your professor will be upset with you, your patients will be shouting at you, the patients' families, they will be like always unhappy, and working in Pakistan, you will never have facilities, and every day frustration will go higher and higher. But remember, when it gets too much for you, but make it a routine of every second, third week. Those were the days we used to have white coats, if anybody remembers. And ties were a definite thing. You don't take tie off. You will be basically, professor will tell you off if you did not have a tie at work. Nowadays, if you put a tie on, then you get fined. He said to me, take your coat off, take your tie off, roll your sleeves up, and go and sit to one patient who is dying under your care. And I said, why? And he told me that lesson, which I did not understand at that time, and I know now. He said, it will give you the humility which you need for your practice, for the rest of your life. And brothers and sisters, these are the skills we need to develop as community to look after these people. There are people dying in our community every day, very in difficulty, not happy. Why? Because we only decided, forgive me for saying that the palliative care is only end of life and the last days of life. We did not prepare ourselves as community way before. That all of us, how many of us are going to die? Oh, all of us. It sounds very pessimist, but that's the reality. So we do provide them palliative care in different words, but this is the WHO document which says the communities need to be doing palliative care. All of us have to do palliative care. I'll just skip that. And I know we live in a high income country, or most of countries. So people who are here, considering if they have come from Europe, we are very self-sufficient in having all the resources that we can think of, and we do that. This is again WHO document. Middle income countries are coming up, and low income countries do not have much. But there are barriers which are identified across the world. And these are, we do not know what palliative care is. We do not know what we should be doing as community and as society and as even professionals. We have got limited policies, shortage of professionals, and opioid access, which we'll talk about later in the day. But brothers and sisters, I would argue, in my experience, and again happy to be challenged on, I think we have got the best resource, which is our families and community. 48% of the hospital beds in United Kingdom right now, we cannot discharge patients. Why? Because the families or communities are not able to look after them at home. And they are taking the beds. I'm not saying they have to, but the majority of the time I have come across when for example, my mother was unwell, we never had that discussion. We said, yeah, you did the treatment, we are taking her home. That's the biggest palliative care resource you have in our community. People are able to pull together to look after them. Obviously, you need hospital bed and like mattresses and stuff like that. But in terms of providing that emotional and psychological care for our patients, I honestly believe you have got the biggest resource. And these low-income countries have got the biggest resource. So just to give you a bit of background, this document was agreed in 2015, Ambitions, which now is revised in 2020. And if you look at it, apart from third one, which is talking about maximizing comfort and well-being, and you need to manage pain and radiotherapy, all of that makes common sense. All of that we should be doing as community. And we should, and they are expecting us on the last point that every community is prepared to help. That's the ambition internationally to achieve good palliative care. Just one slide. This is that model we actually got from Scott Murray from Edinburgh back in late 80s, early 90s. That in the beginning of the disease, you do specific disease treatment as much as needed and very tiny palliative care. But it runs alongside. And that was taken a very much gospel. This is what we should be doing. As the time progresses, it could be over a few months, could be a few years, it could be 10 years, 15 years. But we need to look more at disease curing treatment, but a bit of palliative care, a bit of psychological support, emotional support. The reality is this, that you come in and out, in and out. And this is where all of us need to pull our sleeves up and look after them, sometimes more, sometimes less. Because this is what hurts patients more. Just talking about loneliness. Disease, which is life-limiting, is a lonely journey. No matter how close we are to my father, my partner, my children, if God forbid, if they get ill, but it still remains very lonely. And this is why we need to be there for them. Any question or any comment you want to send through Slido or just shout out? Have you got a roaming mic?
Assalamu alaikum. You were talking about the palliative care, so especially for family members, etc. My friend and I have been visiting seniors every Friday since 2017. And what we found that it's not just the person who's unwell. Obviously we visit them over years before they pass away, just because they're alone. But we find that it's also important for the community to know that the carer of that person who needs also needs someone to listen to them, because no one sees their suffering. Yeah. They don't see how much work and effort they're putting in, because you're looking at the person who's not well. But the carer is, like, especially if it's someone in the house, it's not carer coming from outside, but the son, the daughter, the daughter-in-law, they really struggle. And they actually, because we used to go visit an elderly lady, and her husband is as old as she was. But he looked after her because health-wise, he was healthier. But we found that we'd have to go for a couple hours and talk to him as well, so he could express, this is what I did for her, this is what I do for her every day. So I think we shouldn't forget the carer also needs the community.
We shouldn't forget it, yes. Isn't it? Yes. Thank you so much. Exactly is what I was saying about patients die, but families don't. We keep on suffering. Bulana, from Islamic perspective.
I just wanted to share one more I think your discussion more about making palliative care a common issue. This was a very interesting, move from medical profession to a community activity. Looking at the question your sister, or the comment that she made, I remember a gathering I had with a church group that asked me to talk about Islam. Interestingly, when I went there, I realized this was their seniors group. So after the discussion, everything, I stayed with them and I saw how they conduct their seniors meeting. Something that I learned from there. And I talked to our community about it, but our communities, the leaders are here anyway. They listen quite a lot, but they do something that I wanted to share here, since I remembered that. They actually, the senior committee there, they had divided themselves into junior seniors and senior seniors. Junior seniors means those who are seniors but still mobile, active, can travel around here and there. So they would actually pair for example, if there is a couple who is classified as junior seniors, they will be assigned to go and visit at least once a week a number of senior seniors. So four maybe, senior seniors were assigned, and they'll go once a week, go and visit them, sit with them, see if there are any issues. Mashallah, our senior groups, I don't know, I'm not talking about London, so don't hold me for that. They only talk about trips and cruise and this and that. These are the issues that we have to think about. Okay.
Thank you so much.
Look, it's no point now giving medication or drinks to my relative. Can you stop? How do you, because I used to run a home and I used to come across that a lot. What are your views when you are told as a professional, doctor, can you stop any medication or feeding, whatever? What do you do then?
This is a huge question. Inshallah, during the day as we go, when we come to firstly advanced care planning and then withholding the treatment, then inshallah, if that's okay, can I hold this question and then we can answer at that time? Inshallah. Thank you so much. So how do, sorry.
I just wanted to make a comment here because unfortunately I can't be here later on. I'm very glad that this event is taking place because the issue of end of life care is one component of the bioethics, which is broader. And we were in Canada last month, and the Imamiya medical doctors were there. This was one of the discussion points, and there were many other points that were brought forward. And going back to the ulama, and the role of the ulama became so paramount that the issue of conscience, doctors who need to make decisions instantly became so severe that there were those who are saying that if we don't make a decision of life and death in 7 minutes, we can't wait to send the question to Najaf to get a response. We need something instantaneously. So I think the point I'm trying to say is going back to your early question about your conscious, the different environments and how do you deal with that. I just want to comment the fact that this is taking place, and I hope this is the beginning of the journey where we can involve Maulana Sahib and other scholars to be able to respond to some of these very important questions. Thank you.
Exactly. Thank you. Thank you so much. That's why we need those guidance. Thank you.
Can I be bold enough to make a statement that might hurt some of you? To me, my personal experience, when I first learned about palliative care and what the word means, to me it seems like an elitist creation. That this is something to look after only a certain group of people. When I say elitist, I don't mean rich or poor. I just mean separation to a certain group of people. There are so many people who die without us ever discovering that they're going to die. Whether it is from a life-threatening disease, as you say, or by other causes. Yet, they never receive the benefit of palliative care. So to me, as a layperson, and you'll excuse me, doctor, this appears like something we are struggling to do or create for only a certain group of people. Some people who we are sure are soon to go. I mean, to me, that's palliative. Somebody who is 90-year-old may not be declared under palliative care unless there is a diagnosis which confirms a life-threatening disease. How do I reconcile with this? I mean, what steps do I need to take to be able to understand what palliative care is?
Thank you. I think again, hopefully I'll try to answer this one as well later on, but because they are very pertinent question. First of all, if you're 90, or let me put that one, and before I come to the answer, you should still be, everybody in this country after 75 years of age should be screened for frailty, which is taken under palliative care. But secondly, one of the reasons I see in when some of the brothers and sisters talked about the last 40, 50, 60 years of palliative care, because hospices existed before that. And hospices did try to do some good care. What was happening till 1960s, that we were not able to organize it well. So if you look at the hospices mostly, what is the common between them? What is the name? St. Francis, St. Clare, St. Joseph, St. John. Because what was happening that like religious parishes, they put one room aside and declared that hospice. But what they could not do is organize it in terms of medical care, clinical care, and empowering to the family and social work. So they tried to bring it together, hence this circle of palliative care became. The problem is that we have become more and more exclusive club over the last many years. And this is what you want to break back, to say, we need to, this is how Ambitions document was born. We really need the communities to do it. So the professional should be able to guide it, but it's the communities who should be doing it. And when you mentioned that lots of people die suddenly even, when we talk about loneliness, and I do not know, and this is what my hope in initial discussion about this project was, that we need to look at something called, like Sister alluded about care homes, people there she's visiting, is we need to develop something like compassionate community among ourselves under the umbrella of palliative care. So it's not just palliative care patients they look after lonely people. They look after people who among us are left. Which age, for example, when we talk about loneliness, what is the general impression? I'm not talking about talking to clinicians, but what is the general impression? Which age group is the loneliest statistically in this country? Any idea? 50. It is supposed to be, the statistics tell us, between 26 to 34 years old males who basically are not able to have valuable, meaningful timing with their friends. That's what the statistics tell us, and we are leaving them behind. So there are lots of things we are not doing, and we want to. Sorry. Just one last comment before I can move on.
We also have a large number of people now, which is more common in the recent years, who have dementia. And we found that when we want to even visit, the family will say, but they won't know who you are. They don't know, they don't understand. Stuff like that. So I think dementia is also a thing that we need to find a way around. Yeah. Because I don't know what they're going through. We do visit their carers, because that's all we can do. But dementia is, I found that when you have dementia, you can't bring them to the mosque because they can go out and who will look after them. So they're excluded from the community because of dementia, which makes them even more lonely, I think.
Thank you. I mean, this is something for all of us today.
Yes.
Thank you, Sir. I'll just move on to the next slides before we hit the question and answer session properly in the, later on. So when do we actually, now if we talk about, so when we have broadened palliative care a lot, now we want to bring it back together so that we can manage the problem. So when we talk about, let's go to now one part of palliative care, which is end of life care. So when we talk about end of life care, now it's some of this discussion will be clinical. It is really hard for me to pitch here because if we are clinical, you might find some of my discussion very basic. If you're not clinical, you might find a little bit high. So please forgive me for that. This is a very clinical question. How do we actually think about end of life care? When is it? And this comes as a surprise to you that there is a surprise question. My senior, my boss at Cambridge, Stephen Barclay, back in 2004, he went on to do this study. And we thought he was mad. It's just a stupid question. What he did, he started asking the group of people that you are looking after, so these people who are looking after these people, will you be surprised if anybody dies within 1 year? If the answer was yes, I'll be surprised, then they were out of that end of life register. This is how he randomized them. And if you will not be surprised, then you put them, and then longitudinally followed them. In 2004, he found that we were right 88% of the time. So just asking the question, mentally we interpreted the data so quickly and we came up to the question, I will not be surprised if the patient dies. And that produced a lot of good documents. Unfortunately, the last study tells us that this is not as accurate as it used to be. We have dropped down to something like 55%. And there are good clinical reasons behind it. People are living longer because treatments are more and that's going on. But also, the data tells us that we are getting more scared of saying that we will not be surprised if this patient dies. There is a term born in healthcare institutions. It's called thanatophobia, fear of death, which is most prevalent in junior doctors and nurses. So that's why they are not able to commit themselves that this patient is to die. So there are good reasons behind it. But by and large, this question has helped us. So the question is then, what are the barriers if we are not getting it right? And I won't ask any question because we will be running short of time. This is what the data again is telling us. When the people were asked, these were things bad. Because we have got that hope that patient will get better. So we cannot answer the question honestly. Sometimes there's no definitive diagnosis because people are just looking 90 years old frail and we do not know, so how can we commit? But then we want to do all the interventions, but there's a disagreement as well within the clinical teams, how to treat them and manage them. When I was talking about assisted dying at the APPG, and this point I made many times, I don't think they heard, 59% of the doctors registered in this country in last year trained abroad. And guess how much time is spent on, one of the big things is prognostication, that this patient is in the last 6 months of life when they're offered assisted dying, right? Guess what? If you're trained abroad, your chances of learning about prognostication are literally zero. Most countries do not teach it. And 59% of doctors are being trained abroad. How do you actually put that in motion? When you're expecting, the law will expect every doctor to have that discussion. So what they will do, they will either have unrealistic intervention or they will not know what to do about this patient. They will just disagree and it will cause more distress to the patients and families. And this one, another one, poor ability to communicate. And that goes for patients, carers, and everybody else around us. But if we were to get right that okay, we do not know how long this patient has got, but we need to get it right so that we can at least start managing, thinking at some stage this gentleman or lady is not going to be with us. That's the last opportunity to finish our business and create those memories. How many of us are here who will think, I wish I had asked my dad that. I wish I had said that to them. And this is what will should not happen if we have got good advanced care plan for them. Not saying that this patient is to die, but we need to start planning. And again, it's not just end of life care. We know this patient has got illness. If we should do it anyway with every one of us, but if not, this is the time. And if we want to achieve any spiritual peace, that will be the time. Because if we do not do it well, we mess up big time. And how many doctors and clinicians in this room who would have definitely seen that? If we do not get it right, then nobody knows what's going to happen, conflicting messages, and they can't finish their business. And then issues in bereavement. How many people in this country who have lost somebody, we do not know about other, but Macmillan is a cancer relief charity, they tell us, patient who died of cancer, how many of them required either ended upon antidepressant within 10 years, the families, is approaching 40%. 40% of the people who lose somebody, within 10 years, they end up on antidepressant. It used to be less than 20%. So it's a but clinical, which says, how do we do that? What helps us answer the question that we are in the last year of life, and there are things which you can read in the slides later on. So I wouldn't go much on that. But how do we deal with that when we are there? This is what, so if we feel, clinicians and everybody, that this could be the last year of life, or even last years of life, but this particular disease is not going to be reversed, like classic one is, which is my interest, motor neuron disease or multiple sclerosis. And if you're dealing with that, you know that we would not have a cure. So this part of it, I do with, for example, they have got infection. This is what I'm treating. But this is weakness, that's palliative intent. And this is how we need to divide our mindset. We need to improve our communication skill. And like we already heard, we need to enhance not just patient, but the relatives in that. Obviously, law will ask you to seek patient's permission to involve the family. But in my experience, this is not too hard to do. You just go back and say who one will. Classic one is, we say to the patient, your decision. What do you think the treatment? We can do treatment A and treatment B. Now, whoever is the doctor here, who has not heard this back? Doctor, you are the doctor, you decide. Same way, you can put under the law, it's a patient's individuality, but when you go and empathetically and compassionately ask a question, who can you trust to be involved in these discussions? They will always find somebody. Even if they don't have any family, they will get a family, neighbor or a friend. And I believe we have a duty to support everybody. Because you and I just will spend the last few days even, and just hours. They have known somebody for their all lives. Why would they not trust them? And they can be your best ally in decision making. And we integrate the model of healthcare system from active treatment to palliative care setup. So we do it integration rather than this is palliative care, curative care, boom, stop. This is palliative care. No, we need to do it together. All of it. This is what will help the system take forward. And we need to identify medical hurdles, but also there is social, cultural, and even geographic hurdles. I work in Essex, and a lot of it rural Essex. Now it's much better. But the sat-nav did not used to work there when you are sending to do a home visit, and you're scratching your head. What am I doing in the middle of this lake, which I can't find the place? You need to identify those things early to do that work. And as a community, I believe this is what will be the first step for us moving forward. Thank you.
أحسن صلوا على محمد وآل محمد. As perfect timing because we have about 15 minutes now. We've had some questions and answers already, but we have about 15 minutes now for anybody here to ask any questions. I know we're early in the seminar, and I know the major question that we're going to go into is going to be about how we as practitioners manage and balance our duties to where we are working and our Islamic duties upon ourselves. And I think we will definitely spend some time going into that. A quick recap of some of the things that we've learned today. I think there's some lovely things, as Maulana Rizvi was discussing, that we can't run away from Islam. It doesn't leave us. It's always with us, and therefore we must look at how we will practice within our spheres as medical professionals. But also there was this interesting discussion about this concept of istishab and of course of tawaffa, and how those will affect our decision making. And definitely I think there'll be some questions you all will have. And of course, when we looked at Professor Qamar Abbas's points, there's two things that really stood out to me, which I thought I would just share. One of them was that 54% of the complaints that come through are from palliative care, which is, given we all understand the complexities of care, health, illness, especially things like obstetrics and gynecology, one of the most, highly litigious areas, and fraught with difficulties, as many of us have seen and been through. Despite that, over 50%, 54% of complaints are about palliative care. And I remember when I worked at St. Francis Hospice, the consultant who I worked with, she said to me that one of the things that you have to remember is that relatives will always remember and hold on to the last moments and their memories of those moments. So when you're talking about palliative care, it's so important because that memory of how that death is what stays with them. Yeah, we've had a lifetime of memories, but for some reason it's that last memory. And if it was a good memory, they were happy. We looked after their sort of healthcare, and they looked comfortable. Families are so at ease. But as you can see, 54% of complaints. So how does that marry up with how we work as practitioners? And of course, the concept, as Mustafa Uncle asked about, in terms of, is this an elitist area? But if we go back to the origins of the Genesis, the Latin, as Professor Qamar Abbas mentioned to us, and none of us were able to do it. If it was Gujarati, we could have done it, but Latin was difficult. It's about care and welcoming and giving that environment. So with those very quick recaps, I would welcome and open up the floor. There are obviously a lot of other agendas on the items on the agenda that we are going to cover. If there's anything you want to ask, feel free to delve into, because we've got a few Q&As. But I know that later on there'll be so much more. So if there's anything, please feel free. Does anyone have anything? Please, Sheikh Mustafa.
Hassan,
sorry, just one more. If you, we all know who Sheikh Mustafa Jafar is, but if you could please just, whoever speaks, just reintroduce yourself so we all are able to make it more of a community feel.
thank you. My question is about brain death and heart death. Like Maulana Sahib, you rightly said, brain death has been a more recent concept. But what is medically and through experience the time lag between brain death and heart death? Is there a link? Is somebody who dies under the definition of brain death is soon to die the heart death as well? Is there a time element that then warrants the fuqaha ruling on division of estate or control of all earth?
I think before Dr. Abbas gives a medical, opinion on this issue, let me just share with you, because I get these scenarios and questions from all over the world. I don't know how. It seems my name is sprayed in a wrong way, this way. All the way from South Africa to Nairobi to Pakistan to, of course, in North America, even UK. Um, in many cases that even I have dealt with, even in Toronto itself, Alhamdulillah, we have some doctors in the community with whom I touch and we consult issues. Because before I advise the family, I need to know the situation fully. And sometimes if things are not clear, I would then ask the doctor to talk with the doctor at the hospital to find out exactly what's going on. This is just a simple observation that I have, because the doctors will say it's time to pull the plug. Of course, they don't use these words, but you know, and we say you can't do this. And so, in majority of cases, I think the hospitals and doctors have respected the wishes of the family. And I would say that to them that, tell the doctor, give us 2-3 days. And this is not a scientific, data or anything like this, but I think within 2-3 days, the patient will die without withdrawing the life support.
MashaAllah, that is actually the guidance. So 3 days. But obviously it depends on, for example, if it was a hugely traumatic road traffic accident in which everything is broken, then it could be earlier than that. But generally for long-term illnesses. Sorry?
The NHS doctors...
this is the NHS guidance.
3 days or 1 day? Because my experience was 1 day. They said, we'll give you a day.
I think this is where doctors are bad. The decision would be made 3 days, but they do not approach the family in a timely fashion. So by the time they come to have those discussions, actually the decision was made 2 days ago. That is my personal experience. I'm so many times involved in that. Where do you think this 54% of the complaints coming from? It's bad communication, which is happening. So, so yes, you're right. I mean, it is really left to the late to come and say, actually, and I'm sure that the phrases they would have used is, we had a discussion and multidisciplinary team sat and then we decided that this is. So why did you not tell us when it was happening? So yes, as a doctor, I take responsibility.
So thanks. Because you answered that question right, that's why you're getting more questions coming to you. Any other questions from the ladies? Please, Shanazan.
Assalamu alaikum. So this is about my sister. She was diagnosed with an incurable disease, but the neurologist told her that she will end up not being able to swallow, and her whole body is going to shut down. And she signed a document and said that she did not want to be resuscitated, and she also refused to be fed by a tube. Now, her condition was, towards the end, she couldn't even swallow. She couldn't even drink water. But so it was very difficult because she'd already signed that document. The nursing home she was in, they were like, well, we can't do very much. But alhamdulillah, we didn't get to that position where she had to be fed by a tube or needed resuscitation. She passed away peacefully, very quickly. But what do we do in that situation, as a family? What's the ruling? Is she allowed to do that? And we know you can't make that decision at the time because the nursing home was like, well, she signed this document, so you can't do anything.
Clinical part. Okay. I will take the clinical part of it. Really sorry to hear this, sister. I think important thing here is, and I believe we'll explain a bit more. When you write a document of do not resuscitate, we do not expect the patients or the families to sign it. It is a clinical, according to the law in UK and Europe. I can't remind myself about Canada, but in Europe, it is a clinical decision which has to be signed by 2 doctors. So even if the patients make a decision and request, it can be taken into account, So the process is different. It's not that they should sign it. They can sign an advance decision to refuse treatment, which means that they can say, I don't want a tube. But this is where I have said it before as well. As a community, we need to promote more LPAs, lasting power of attorney, because even if I think I want to refuse a treatment, I do not know what my condition will be then and when I lose my capacity. So I need to identify in my family somebody who can be my advocate at that time. So I'm really sorry you went through that. I'm a huge proponent of LPAs against ADRTs.
From the Shari point of view, this issue of DNR is a very difficult one. Ayatollah Sistani doesn't allow that at all. He says you cannot sign that. And even if it's signed, it's not valid from the Shari point of view. Sometimes it becomes very difficult. You reach to a point where you know there is no cure, so why revive the person again? I'd asked some questions. I haven't yet received the answer as of this morning, more about this issue. But at the moment, the opinion of Ayatollah Sistani, others I don't know sure about it, but he says no, you cannot sign a DNR form. And whether it's the patient himself or herself, or the wasi, somebody who has been given the power of attorney to decide on behalf of the patient, that applies to them also. And as far as, the issue of not being able to swallow food or drink, there are different levels. If the main perspective from Islam would be that you cannot let the patient die of thirst or starvation. So you have to provide nutrition in the best manner you can. If the person doesn't have the ability to swallow, if the tube can be used, then that should be used. But that also, I understand, cannot be used for a long time. There are complications there also. But if they have used it and then it reaches to a point that even that is not working, then you can't really do much. But whatever is humanly possible to provide the nutrition is wajib. Yeah.
Sure, we've got some more questions, please. I think she got two questions. Yeah.
Thank you. Because you asked me to introduce first, my name is Syed Imran Qasim. Wear two hats: fraud investigator, British Airways; resident alim, Al-Qaim Islamic Mission, Slough, both. I'm trying to make this question coherent mainly for Dr. Professor Qamar Abbas, and also Maulana Sahib can give a perspective on this. UK, and where we live, we have a lot of loneliness, like you mentioned, and the issue is about people might be getting more towards depression, but they don't want to be given medication for depression because they're very educated in what the side effects of these medications are, and they don't want to give them these medications because it'll make them more sick and they'll feel worse off. But the loneliness, the low moods are not going away. What is the status of the law? I mean, does it mean that if somebody is diagnosed with severe depression or something like that, they'll be sectioned? And what can somebody get out of that situation? How do we remove the fear, let's put it like, I'm trying to make my question coherent here. How do we remove the fear from the patient or the person that, they'll be taken care of and they just won't be will be getting just pills and will be let to be in the system?
Could I ask, is that within a palliative care?
It's a person who's not going to
health?
die. I mean, you can't see the person say he's going to die or she's going to die. But you can see that they are going through a stage where they need to be treated.
Sure.
but they're refusing the medical, the pill treatment, let's put it that way, because it causes more side effect, and they'll be even worse off, and they won't be able to live even the quality of life that they're living now. How do we reassure persons like that that the treatment is going to get improvement, what the side effects are going to be, and what the sectioning laws in the UK are and all that? Okay. Maybe Morana also can give a...
Well, I was going to forgive me. It's got so many questions, and also on Slido, and because today's remit is really about palliative care, and I would probably suggest, unless we're looking at it from that patient being someone who's in sort of an end of care or death sort of situation, I think it would fall more into a mental health type of question, which is definitely something very important, and we've had the seminars. But if it would be okay, I think with your permission, we can pick that up maybe in the break, and we can discuss it. There's quite a few of us who can, if that's okay, who can go through that with you. But certainly a very important question. Dr. Munir had a question, if that's okay.
So, Maulana Sahab, you have just confused me now. In your presentation, you said the consensus amongst the mujtahid is that if there is no heartbeat, if there is no pulse, the patient is dead. And you just said that the mujtahid said that they cannot sign a do not resuscitate document. But the resuscitation only happens in the community when the person is already dead, i.e. he has got no pulse. So we will only resuscitate someone who has got no pulse, and when they sign or they agree to do not resuscitate, it only happens after they have no pulse. So if the mujtahid have got consensus, when there is no pulse, they are dead. So I'm a bit confused now that they are saying that they should not be agreeing to do not resuscitate.
So this is a really good question, because also within this, there's the question of how far can we go as a treatment if someone's lost the pulse. Is a treatment to bring them back, or have we just accepted that they've died? And if it was a young person, for example, we wouldn't accept that. So definitely one for both of us.
Well, I don't see any contradiction there. See, the issue is that whether you go with the brain dead definition or heart dead, the mujtahideen, basically people like Ayatollah Sistani, say that if you are able to revive that person, then you have to do that. And now this is not a fatwa or anything, it's just the way I have seen the examples. If there is a case where there is a cure at the end and the person has gone through, the heart stopped, then reviving in a way becomes wajib, because you can revive the person and then cure the person. And that's why they are saying DNR is not allowed from the Sharia point of view. But if there is no cure, then this is where I have this problem in my mind, that why I cannot sign DNR, because there is nothing to be done after that. There's no possibility of cure. But the opinion still says you cannot sign DRN.
Can I come clean?
Please.
I think this is obviously with esteemed ulama in the room and other places. I'm not going to definitely indulge in that. My personal feeling is DNA, or my teachings have, DNA CPR discussion is not at the time of when it has happened. It will be happening way before that, which will include the discussion about, is it, when we do resuscitation, is that resuscitation going to do more harm than good? My background is that in cardiology, as everyone knows, that before I switched to palliative care, and we used to use the phrase that you have not done a good CPR unless you have broken 2 bones. So you have to apply yourself to do that. And phrase I use in my teachings, CPR is not a treatment for death. CPR is a treatment for cardiac arrest. If the patient's heart is stopping because of a reversible condition, That's when we do CPR. If it is respond because all the organs have failed, then CPR is not going to bring you back. I'm talking about evidence base here. I'm not talking about Sharia or anything. So my feeling is that in order to do good to our patients, we need to know the evidence before we go there.
Okay, thank you. I think we can. I think we are actually running a little bit behind time. I would probably welcome one more quick question from the table here. Oh, okay, we can. Please, yeah. We're gonna have.
Can you hear me? Sorry. Yeah.
Yeah.
Assalamu alaikum. I'm Naseem from Hujjat Cancer Support Group. Basically, two things. Qamar Bhai, which I also heard about the lasting power of attorney and all that. When I was working for Macmillan, they have the document called the living will. The living will is where, whilst the patient is of sane mind, alive and healthy, you make your wishes known. So if there's lasting power of attorney, do not DNR, all that. So that's one thing which I thought was quite interesting, which you can do that. And then the second thing was the home and a hospice. There's a difference in the sense when my sister was not well, I went to Canada in Vancouver. Assistant dying is very common there. It's given to the patient as soon as you go in the hospice. The form is given. Do you want this choice? We were really concerned about that because I think the term is very loose there, and it's accepted very widely. I'm here, obviously, now the law has come, but I'm quite worried as to Islamic perspective is, you're not supposed to sign any document. But when the patient is in so much pain and maybe not in the right state of mind, the patient might sign it. Like Shehnaz mentioned that her sister said, do not feed me and things like that. So we told my sister, you are no way going to sign this document. But when you read the first document, you're interested in the second one. So she asked for the second. And then I said, you do not ask for the third one, because that's encouraging the patient to sign the document. And we even asked the doctor that, can you please let us know if that stage comes to that? And they said, well, no, we don't have to, because it's the patient's wish. So there's a lot of discussion here as to Islamically, yes, you're not allowed, but the patient is in so much pain that the doctors will listen to the patient. So in Canada, it's very, very common. So I just wanted to, it's an observation that was, but obviously she didn't make it, and she also told me that I'm in the hospice, I'm not here to die. I'm here to get better. So the term hospice can also sometimes be there as a recuperation, you're getting better, you might even go home. The doctor said 3 months, but you might live longer.
Ahsan, that's a really valuable reflections. Definitely the two good learnings from the hospice care is not, and doesn't mean the end. We often have respite care, as you've mentioned, and recovery. And the concept of the living will is a really great idea that we can definitely look at later. But it is a brilliant thing that Macmillan have done. We're going to take one more question, and then we are going to move to a break. There is the Slido still. There's already 5 questions populated, 6 questions coming through. So please, if there are questions we're not having time to, please do.
Yeah, my question, thank you very much. My question is directed to Dr. Saab. I mean, it's learning for me at least. Palliative care, you said, covers both. It covers the patients and it also covers the relatives or the carers. So my question is more directed towards the carers, and you have been talking throughout about community support that is needed. And I totally agree with that, because at the moment, I know of cases where we have old couple living together. One of them is extremely ill. The other one has to take care of the spouse. And the case which I have at hand is the husband is quite sick. Practically every week or 2 weeks he has to be hospitalized and then brought back and is immobile. And the wife, who is not young, has to take care. It's not that they don't have children, but the kind of life that exists here. The children are busy, they are working, and they have grandchildren and so many responsibilities. In such moments, we find that they tend to resort to us who have been in Maulanas, as people would call, for counseling. But it is quite detrimental for those who are acting as carers, especially spouses, and it affects their mental health like anything. I mean, they literally are as if pulled down in their lives. They have practically nothing to live for. In other words, they can't go out, they can't do anything. They are continuously there. And lately, with the system which is prevalent here in the UK to get nurses or to get carers, is not easy as well. I mean, there is a lot to fight for. I have seen that the names which were on the slide of the champions in each area, it would be very important to know what their roles will be, number one. Number two, how does the community come in and play the role? I think this is one of those things which we need to discuss and come up with, because this is just few cases I know of, but it could be everywhere.
Please, I think very briefly, I think this is first of all, the roles of the palliative champions is to navigate the difficulties with the treatment and how to support the family. That's my hope. And the second is that my real hope and pray is that as community we can come back to develop a compassionate neighbor scheme in which we can support each other even before we are in that stage. So it's a much more smooth transition when we get there. So yes, so it's a wider call. MashaAllah. That's why I'm saying it.
Asa, thank you so much for those questions. Please submit them on Slido. We're going to take a little break. In the interim, I've put the slide up for what the roles of the community champions are. Feel free to have a look at them and discuss with each other. And I'll ask you to be back in your seats by 11:20, please. Thank you so much.